So vogt-koyanagi-harada syndrome, VKH syndrome. It is an idiopathic multisystem autoimmune disease featuring inflammation of melanocyte containing tissues. Melanocyte containing tissues are, for example, uvea, ear and meninges. Uvea, ear and meninges. So integumentary, neurologic and auditory involvement. VKH predominantly affects Hispanic, Japanese and heavily pigmented individuals, usually in the second and fifth decade of life. It is associated with HLA-DR1, HLA-DR4 cross different racial groups. VKH is sometimes divided into a vogt-koyanagi disease and it is divided into vogt-koyanagi disease and Harada disease. In vogt-koyanagi disease there is skin changes and anterior uveitis, and in Harada disease, in which neurological features and exudative retinal detachment predominate. The clinical features: there is prodromal phase, then there is acute uveitic phase, then convalescent phase, then chronic recurrent phase. So first is prodromal phase. It lasts a few days. There are neurological such as meningitis, rarely encephalopathy with cranial nerve paresis and other focal lesions. In addition to neurological, there are auditory manifestations. Auditory manifestations, for example, tinnitus, vertigo and deafness. Cranial nerve palsies and optic neuritis may occur. So in prodromal phase there are neurological and auditory manifestations. It lasts for a few days. Next is acute uveitic phase, in which there is bilateral granulomatous anterior and multifocal posterior uveitis with diffuse choroidal infiltration. There are Taylor-Fuchs nodules, vitritis, papillitis, exudative retinal detachments, ciliary effusion with iris lens diaphragm rotation can occur. So this is exudative retinal detachments, and these are Taylor-Fuchs nodules. In acute uveitic phase, these occur. Then is convalescent phase. It follows several weeks later. There are localized alopecia, poliosis and vitiligo, depigmented fundus appearance, also known as sunset glow fundus, and depigmented limbal lesions, Sugiura sign, depigmented limbal lesions in pigmented, especially Japanese patients. So in convalescent phase there are alopecia, poliosis, vitiligo, sunset glow fundus. Next is chronic recurrent phase. There is smoldering anterior uveitis with exacerbations. Recurrent posterior uveitis is much less common. Diagnostic criteria for VKH. So this table shows diagnostic criteria. For complete VKH, criteria 1 to 5 must be present. In incomplete VKH, 1 to 3 and either 4 or 5. And probable VKH, in probable VKH, criteria 1 to 3 must be present. Probable VKH, also known as isolated ocular disease. So for complete VKH, first one is absence of a history of penetrating ocular trauma. This differentiated from sympathetic ophthalmitis. Absence of other ocular disease entities. Third one is bilateral uveitis should be present. Fourth one is neurological and auditory manifestations such as tinnitus, vertigo, meningitis. 5 is integumentary findings like poliosis, vitiligo. For incomplete VKH, 1 to 3 must be present, and from 4 5 only 1 should be present. And for probable VKH, 1 to 3 should be present. Ocular complications include choroidal neovascularization, subretinal fibrosis, preretinal and disc nerve vessels, vitreous hemorrhage, cataract, glaucoma. Prognosis is variable and is partly dependent on achieving control in early stages. Neurological and auditory manifestations tend to resolve, but skin, lash, and hair changes usually persist. Investigation: systemic manifestation should be investigated and managed by an appropriate specialist. Lumbar puncture, if diagnosis is uncertain, CSF shows a transient lymphocytic pleocytosis and melanin containing macrophages. FAF demonstrate areas of serous detachments. Ultrasonography shows diffuse choroidal thickening and excludes posterior scleritis. UBM can also be used to demonstrate ciliary effusion. FA of the acute phase shows multifocal hyperfluorescent dots at the level of retinal pigment epithelium. Followed by subretinal pooling. The chronic phase shows RPE window defects. OCT allows quantification of subretinal fluid. The subretinal septae are typical. The ICGA during the acute phase of the disease shows regularly distributed hypofluorescent spots. Treatment: high dose 1 to 2 mg per kg per day oral prednisolone, tapered over 3 to 6 months, preceded by intravenous methylprednisolone pulse therapy, which is 500 to 1000 mg per day. Topical steroids and cycloplegics for anterior uveitis. Steroid resistant patients require immunosuppressives. Biological blockers such as infliximab should be used early in the course of the disease. There is no response to steroids.